On this episode of the Ask Mike Reinold Show, we talk about why you may feel worse the day after a treatment. We talk about how to develop your own Con Ed plan, and we also review kind of our current thoughts on blood flow restriction training. The Ask Mike Reinold Show. Helping people feel better, move better, and perform better. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We're at Champion PT and Performance up in Boston, Massachusetts. Why don't you guys introduce yourselves? Why don't you tell me your name and where you're from?
Well, I'm from New Jersey.
What's your name?
Mike Scuduto, MikeScuduto.com.
From New Jersey? That was fantastic. Dan, that's good. A little something about Mike. Maybe we'll do this next episode. A little something we don't know, but Mike's from New Jersey.
We're going to unfollow.
Hello, welcome to the show.
Oh, hi, my name is Dan, guys. I'm from New Jersey also.
I
Nice
like
to meet
it.
you.
Dan Pope. I don't know why people aren't telling us who they are, but I like this good. Welcome to the show.
My name is Dave Tilley. I like long walks on the beach and dolphin safe tuna.
Excellent.
From Trader Joe's. I like it good.
Hi, I'm Lenny McCrana. I'm from Winthrop, Massachusetts, and I used to work with poop.
Oh, your daughter, you're still doing daily basis.
I feel like you have to back that up now.
At a wastewater treatment plant in Boston.
Physical therapy for poop.
He does not do that anymore.
I don't do that anymore.
Oh, this one's getting off to a good start, boys.
Right. On that note, take it away. Brooks Klein from UNLV.
Kobe from LA.
Kobe from LA.
I saw that, by the way.
That's not
so
real.
I just want everybody to know this question is from Kobe from LA. So one, that would be crazy if this really is. So Kobe, tweet at us if this. If this, I don't think it's the Kobe.
There's a
How do I
whole
increase my jump
generation
shot
of kids that are growing up from
In
LA.
LA,
They're not
that's a
Kobe.
good point. He's like a 12-year-old
It's
kid.
like all the Brady's, they're in Boston.
That's good. Yeah, that's actually a good point. So, one, I like it. I think we need to start seeing more creative submissions like this. But assuming that's not really
This is
your name.
Rob
So,
from New England.
all right, Kobe from LA. What question do you have?
If a patient gets worse after treatment, not necessarily immediately after treatment, but the next day after treatment they're in more pain, what is the first thing you do? I.e., do you give them a call right away, and what do you say to the patient?
So this actually does sound like Kobe Bryant from LA. That's actually interesting. So, all right. So as a physical therapist, and is this physical therapy or fitness or both? Or does it say? It doesn't really say like. All right. So we said treatment, though, right?
Yeah.
All right. So treatment. So if they're worse the next day, what do you say? What? Who wants to start? What do we think, Mike? All your patients are worse the next day. Why don't you?
He's now taking new patients. If anyone's.
Why don't you start it up, Kobe?
Okay, so it probably means maybe we overdid it. It depends on a lot of different things, like what's their diagnosis, what am I even seeing them for, I don't know. But if it's like a tendinopathy type thing and they're a little bit sore the next day, I'm probably okay with a little bit of soreness. If they're post-op and I did a lot of range of motion on their shoulder and they're really sore, then that's probably not okay.
Right.
So it depends, obviously. But yeah, just looking at the volume and the workload that you're putting them through, and using that 24, 48-hour kind of test to see if their soreness increases, and did we do too much or did we not do enough, kind of finding a good place for your treatment.
I think it's good.
I
I think that's a good answer, right? It definitely varies. I think like you should know. So I'm going to assume Kobe's maybe a little new, or like a new grad type thing, because I think you kind of get the hang of that pretty quick. Like within the first year, you probably get the hang of that. I could be wrong, or but you kind of know like I have a kid right now that's tight after a bank arm repair, so we're cranking on him a little bit. If he wasn't sore the next day, I'd be like, gee, I better try harder next time, right? Like, you expect a little soreness. Or with the tendinopathy, like Mike said, like perhaps you're intentionally wanting to do that. But we kind of always talk to him like half my job, and maybe it's because we just work with a lot of athletes, it's just calming the patient down. Everybody's panicking at all times, especially like 2 weeks before spring training. Everybody's panicking, right? But it's about calming down. You never want to panic. The second you panic, they panic. right? And then it becomes a whole thing. So do you call them the next day? I mean, yeah. I mean, I'm not against you calling them the next day, but you know, you almost gotta, you have to assess the situation and just be careful with that because you don't want to make a mountain out of a molehill.
Yeah, I think a lot of education before your treatment on what the goal of the treatment is goes a long way as well. If you say, like, we're upping your weights in your exercise program, you may feel a little bit sore tomorrow. That helps keep them calm.
I like that. Yeah, that's a good point.
Education
But, I mean, is it ever bad the next day? What do you think, Dan?
Well, I guess just to add real quick, I think it's important that you just set the standard and tell people, like, pain is first and foremost not necessarily a bad thing, so you got to kind of change that way of thinking for patients. The other piece is that you just tell them it is experimental. We're going to give you what you feel is best. You'll probably be fine, but if you're dying the next day, you got to let me know and we can just tweak things, but don't freak out if that happens.
Right. You know, the analogy I always kind of give to, and let's use this for like a throwing program for an overhead athlete, like a baseball player after surgery, right? You can extrapolate this to anything though, right? But like we always tell people, like, look, when you first start playing catch, it doesn't always feel great, right? But like when you're throwing at 60 feet and it's a little cranky because your body's not used to it, what tends to happen is when you progress and now you're at 75 feet's a little cranky, but now 60 feet feels good. And then the next day, 90 feet's a little cranky, but 75 now feels good, right? It's like you're gradually applying load to the tissue, and it's our job to make sure that we're not applying load too fast or too slow. And going back to Mike's tendinopathy thing, if you're using a 0 out of 10, you may never get better, right? Because you're not loading them enough to actually get that. So, awesome, sweet, good. Fuzz?
This question's from Abby from Seattle. Happy 100 episodes. You guys are really great and have significantly impacted the way I treat patients.
Thanks, Abby. Thanks, Abby.
You always seem so humble when it comes to how highly regarded your products are.
Oh, I like Abby.
Abby's
Thanks.
Thank you, Abby.
More questions from you, Abby.
Yeah, Abby, you get a free pass from now on. Any question you want to ask, just butter us up beforehand.
If I want to work my way through your products, we can only do one option per year. Would you start with your inner circle, the knee seminar, the shoulder seminar, or the functioning stability series? Did Dave and Dan complete all these programs, and in which order did they recommend them in?
All right, so I really like Abby. I mean, everything about that question was perfect.
I
right?
know.
It's helping us self-promote. So I'll give you a little story. Here's actually a story. Dan, how long have you been working here?
I guess it's been about a year and a couple months now.
All right, so Dan's been here for over a year now, we'll say, right? And I literally just got like a ping from one of my virtual assistants that is probably listening to this video right now, right? And they just pinged me and they're like, hey, Dan Pope's credit card was declined for his Inner Circle membership. Do you want me to contact him and get a new credit card info? And I was like, oh, that's hilarious. Dan's been a loyal Inner Circle customer for a while. So I think, did we ever hook you up with free access?
I think you do, yeah.
All right, sweet.
I've been a member since like probably you were like 2 webinars in when I first.
Thanks.
All right.
It's Dan and Abby.
Ride or
We're
die.
a great group of people. No.
Ride or die.
So that's actually, so to answer your question about Dan and Dave, then yeah, I mean, obviously, I mean, we're, I'll let you guys answer that question here, but like, I think we all have learned similar stuff together because we want to have the same model. But to answer your question, you're right. We have a lot of products, right? Lenny and I have a big knee seminar. I have a shoulder seminar thing that's, very detailed for each of the joints. And then there's the Inner Circle. If I really had to pick the order you go through, I think that's really hard to say the order, but start with like knee or shoulder and pick the one that you're seeing the most patients of, or maybe the least patients of, right? But the one you want to learn the most, because knee and shoulder are just jam-packed, comprehensive, deep programs. Once you've gone through those programs like that, then like the Inner Circle is like a good, like, hey, let's just stay fresh, let's stay current, that type of thing. But it's a little more scattered in terms of just diversity of topics. So I mean, that's how I would answer it. But I don't know, you guys say anything different?
Yeah, I mean, just like you alluded to, my beginning of practice, I quickly realized that I needed more information. It was based on what I was seeing. I mean, I was treating a lot of shoulder, more CrossFit, kind of like overhead athletes. So I was like, oh, the shoulder course makes sense. And then honestly, I kind of deviated a little bit, not from a course of yours, but I was treating a lot of low back. So I took a couple McKenzie courses and I read a lot of Stuart McGill's work. Like, all right, I feel like I got a grasp on this. Then I went back like, all right, the knee is probably the next product. I think by that time I was working here, but I started doing the functional stability stuff because I wanted to become a strength coach and I wanted to, I respect Eric a lot. He's helped me a lot in terms of like knowledge. I'm like, well, this makes logical sense. I've gotten through my sports boards and I'm trying to be a better strength coach. And I actually do remember I bought all of the FST ones together and I just binged for like a month. It was a sad point in my nerdy career.
You like Netflix binged
Mikey, when Mike and I were just Facebook friends, he was like, wow, you got a lot of work to do. And I was like, I'm on it, man.
Did we have that
We
conversation?
did, yeah. Because I couldn't log in and you were like, whoops, my bad.
Yeah, interesting. That's funny. So part of why Dave works here is I kept bumping into this knucklehead everywhere. Like he's at every freaking course that I was at, and he was everywhere. So I'm like, well, this kid must be smart. Let's get him in here. So
Debatable.
yeah, debatable. So I don't know. To answer your question, it's very diverse. You can go in lots of different approaches, but I think you got to go by what you're most passionate about. And
Completely in line with the population of people I was seeing.
yeah, right. Like so do something that's going to be impactful on me. So awesome, right?
One thing is I say, I'm a little biased too, but I mean, continuing education is obviously very expensive, right? It's something you spend a lot of money on. Like your inner circle is like dirt cheap for like, I don't know if you've calculated the amount of hours that you put into webinar footage on that thing, but you've been doing a webinar every month for how many years now?
Yeah, I don't even know, like 4 or 5 years.
Yeah, you've got tons and tons of information on there, so there's lots of good stuff in there.
This is the best episode ever. Yeah. I really appreciate this.
I would recommend doing the knee though.
There's really good MedBridge courses with LendMac PT promo codes.
Just kidding.
Hey, if you want peak shoulder performance, just let me know.
Well, yeah. You like yelled that as if like that would make her hear it better. Like you're yelling through the camera. Well, in all honesty, to tease you a little bit, I don't want to make this like promotional. To tease you a little bit about the future, I actually hear what you're saying about the path to go through, and we're actually working on that here. So we're about halfway through or so. I'm putting pressure on us of kind of actually finally coming out with like our full system of performance therapy and training, like how we do things here at Champion, how we all do our physical therapy and our performance stuff. And I think that's going to be the no-brainer starting point for people, because it's like, here's a full system that's going to teach you everything you need, and not theoretical stuff, not everything, but like here's exactly what we do and exactly what you can do. You know how to assess and do the exact treatments on day one. So you're going to start there, and then when you master that, you say like, hey, you know, I stink at shoulders, I want to do that. I stink at knees, I want to do that. That's the approach we're going to go. So we're actually going to solve the problem. So anyway, Abby, thanks so much for that. That was fantastic. I appreciate it. But do we have any like non-infomercial type?
Share now.
I'm just answering a question. You can't say that was Abby.
Last one, Michael from Arizona. I was hoping that you could discuss your opinions and current research on blood flow restriction training in the realm of PT for those that lie outside the athlete category.
I like it. So good. That was all right. So what's our current thoughts on blood flow? It's probably been a while since we've talked about this on the episode, and I think we've continued to learn and play and stuff like that. So let's be specific to the question. But rehab and non-athlete, right? But are we new? What are our current thoughts on blood flow restriction? I don't want to summarize our current. I don't know if we have a standard thought, but
I mean, I've always taken the stance that I think it was quick to market and that there's a lot to learn before we just go like all with it, which is fine. But it's metabolic strain. You know, it's one pathway of tissue hypertrophy and it taps into growth hormone, and I think is good. And I really think that we probably put it in the context of athletes because we see like the post-op ACLs, we see like shoulder stuff, and I think it's really just human specific, right? If you have someone who's deconditioned, has surgeries, just can't load, it's a very good option to try to maintain some of that strength progress. But I still feel firmly that like it cannot replace formal tensile loading, and I think that's where stories from friends of mine who are like using it in their clinic is like they do blood flow restriction training and then they're just like, okay, like I think we're doing well, and they lose out on the other half of like tensile loading, which is so important for tendon health and cartilage health and the other effects. So I feel like people are just, again, quick to market. I just think you got to be cautious about where it fits in line with the whole continuum.
Anybody
but I haven't
else?
changed a lot.
yeah. Anybody else?
I've definitely I've definitely used it more in my population. I use it a lot more for anterior knee pain. I think there is a decent amount of research that's beginning to show that vague anterior knee pain, it does help. So I am using it more. Definitely post-ops, definitely people further out from post-op, like 3-4 months out. That's my kind of initiate a program, get them going, even beyond the leg raises when they're even deadlifting and doing everything out in the gym. I'm still incorporating that into their program, whether it's bike sprints or something of that nature. So I'm using it more, admittedly.
I will say that I think it is probably still good for people who are dealing with pain that are still trying to add maybe some volume from a hypertrophy standpoint. I know I do this. Right now my bicep is kind of bugging me a little bit, and I'm still loading it throughout the course of the week, but on weekends I might do a little extra arm work and I'll put those babies on. And I think that helps because we're not loading the tissue as much.
Loading the arm farm.
But at the same time we're getting the training stimulus, so I think that's nice.
Yeah, that's a good way. That's a good way of thinking about it. So at the sport physical therapy section, or whatever they're called now, but the sports section's big meeting in Vegas in December every year, Team Concept Conference, TCC. They actually had like a big like half-day symposium on blood flow restriction. So I was pretty eager to go to it, watched the lectures by several people on there, and I was hoping to kind of take some stuff back home, and I'm not sure I did. You know, I feel like all the benefits are still theoretical at this point, and they make sense. The question is going to become is, what are the clinical implications of these theories? So, okay, there may be some growth hormone type thing, but how much? Is it enough? How long? Yeah. Is there any clinical implication to it? Right? So I think it's still theoretical at this point. There's certainly situations where why not, right? I think we get some why nots, and I think we're in there. I can't say, though, that, and someone jump in if I'm wrong, I can't say any of us, and we've been using it quite a bit, any of us are like, wow, this is a game changer. Our people are ridiculously strong. I can't say I've honestly seen that. Anyone disagree?
I'm trying, and I'm not. I mean, I'm trying. That's why I'm using it more, because I hear people on social media like, you have to take these courses. I'm seeing like awesome changes in my patients. I'm not. So maybe I'm either doing something wrong, or people on social media are embellishing a little.
Yeah,
I don't know.
It was marketing. It's always marketing, right?
I think we're going to see, as it is now, it's like very good for the prevention of continued atrophy. You know, I think it's going to allow us to start to maintain well and start off at a better starting point for strength. It's not going to be a replacement.
All right, now,
That's what I think.
Not even to get too deep into this though, but I think even the reciprocal inhibition we have to see. We got to question if that's actually a post-operative reciprocal inhibition is neurological versus
Metabolic, yeah.
different strain. You know, it's a whole other issue right there. But you know, we'll get into that. But so, look, we're still trying it. We're still pro trying it.
Useful tool.
Yeah, you know, go from there. Right? Makes sense. Awesome. So that was 3, right? Awesome. Good job, guys, everybody. We appreciate it. So thank you so much. Head to mikereinold.com, click on that podcast link, ask us anything about PT, fitness, sports performance, Lenny's past experience with poop, anything you guys want to talk about. We certainly can. Was that this episode? Seems like an hour ago. Which not that was that long. That was this episode, right? But ask us some questions. Head to iTunes and Spotify. Rate, review, subscribe, all that fun stuff. And is this our first episode that's going to have the explicit language thing on it because Lenny said poop?
Like that's not,
Is that
a swear. I don't know, it's a swear.
I don't know. Interesting. Awesome. See you on the next episode.